Good evening, everyone. I welcome all of you to this evening session on behalf of Indian Medical College. Today we have an interesting topic from surgery on shock, and we have Professor Dr. S. Joseph Philipraj. He is currently professor at Mahatma Gandhi Medical College. He'll be delivering talk on this interesting topic. And friends, if you have any doubts, please type them in the chat section of the YouTube channel below. Sir will clarify them at the end of the session. I'm very happy to and honored to welcome you, sir. Good evening, and you can start your talk, sir.
Yeah, good evening, my dear students. I hope I am audible.
Yes,
and
sir.
you can see my screen.
Yes, sir.
Okay. Today, in this lecture, we will be talking about one of the important topic, whether you are going to be a physician, surgeon, pediatrician, or obstetricians and gynecologists. It is one of the important topic and you will be facing in your practice, and that is shock. Now, my topic or presentation, the learning objectives will be to understand the pathophysiology of shock and ischemia reperfusion injury, the different patterns of shock, and the principles and priorities of resuscitation, the appropriate monitoring and endpoints of resuscitation. These will be my learning objectives for you all. At any time you have any difficulty in understanding or you have any question, you can interrupt and ask me, or at the end of the talk, you can send it as questions. Now, one of the quotes by Samuel Gross: shock is the manifestation of the rude unhinging of the machinery of life. So beautifully he has explained, it's rude and unhinging of the machinery of life, how it will alter the life of an individual when shock manifests in an individual. Now, basically, what is shock? You should be able to understand that primarily it is the failure to meet the metabolic needs of the cell. So very important thing in the whole concept of shock is the failure to meet the metabolic needs of the cell and the consequences that ensue. This is due to lack of oxygen supply to the cells and the tissue. So primarily, the metabolic needs of a cell require oxygen, and this failure of oxygenation and which causes the metabolic needs are not met, and then the shock manifests, and there are many consequences of that which will ensue. The initial stage of shock or initial cellular injury that usually occurs is reversible to a certain stage. So it is the important thing that the treating physician or surgeon should diagnose the possibility of shock early so that the reversible state can be reached only. However, if the injury becomes irreversible, then tissue perfusion is prolonged and severe, and then the reversibility is not there, which may lead to cellular death and even causing mortality. So the basic premise of shock is lack of oxygenation, lack of failure to meet the metabolic needs of the cell, and consequences that ensure because of this inadequate oxygen perfusion to the cells and tissue. Now, briefly about history, you must have studied in physiology, milieu interior, or internal homeostasis, or internal environment in the body. It was Claude Bernard in 18th century, in middle of 18th century, we coined the term milieu interior, which means that maintenance of internal environment is basic essence of human life and maybe in animals also. So the Claude Bernard was the first person who coined the term milieu interior. On his initial groundwork, Walter Cannon coined the term homeostasis. And homeostasis means maintaining the internal environment, and there is stasis of internal environment. He also was the person who coined the term when there is either fight or flight, when there is threat to life, the response will be there, which are multiple, like hormone response, neurological response, everything will be there. And this response was coined by Walter Cannon as fight or flight response. Continuing on these works, Alfred Blalock in 1934, he studied on hemorrhage, making the bleeding and seeing how it is going to happen, various stages of hemorrhage. And he was the one who initially categorized shock into four types: hypovolemic, vasogenic, cardiogenic, and neurogenic. But now another two more have been ordered. Now the current types of shock are: number one, hypovolemic, which is the most common cause of shock, and it is hypovolemia. Next is cardiogenic, septic or vasogenic, neurogenic, traumatic, or obstructive. In hypovolemia, the intravascular volume is depleted. It can be due to acute, like hemorrhage. Either it is visible or not visible. So it is concealed or revealed hemorrhage, or due to dehydration, or due to diarrhea, internal loss of fluids. All these will cause hypovolemia. That means there is intravascular volume depletion, which will cause shock. So the primary thing is, the commonest type is hypovolemic shock. Now, cardiogenic shock is due to failure of the heart muscle, the pump, to function in its normal capacity, and most of the time it is due to myocarditis or myocardial infarction. So the cardiogenic shock is basically due to pathology in the heart muscle. Now, the another important thing is septic. Septic means there is a source of infection which has caused these problems. Basically, the etiology of shock in sepsis is multiple, and we will be dealing with that septic shock as a separate entity in a different class. But it is due to the infection. The primary source or primary eliciting factor is infection, and the reaction of the host to this infection is the manifestation of septic shock. And all these stages are there, which we will deal later regarding sepsis per se in a separate class. Next is the neurogenic. Neurogenic shock can be due to spinal cord trauma. and there will be peripheral pooling of blood because of lack of sympathetic tone and volume. So in most of these types of shocks, there is an overlap with hypovolemia. In traumatic, it may be due to hypovolemia because of bleeding, or in multiple fracture, big bone fracture, or in chest because of hemothorax, or in the abdominal cavity, hemoperitoneum. All these are traumatic causes which can cause the main thing as hypovolemia, which will lead to shock. Now, the other one is obstructive. An obstructive is an entity where there is obstruction for the cardiac output. It can happen in where there is obstruction to heart to pump, like cardiac effusion, or it can be due to pneumothorax. So in these situations, there is difficulty for the heart to pump normally, but the basic cardiac muscle is normal, whereas it will be having problems in cardiogenic shock where there is ischemia, infarction of the muscle fiber, or there can be inflammation, which is known as myocarditis, which will cause cardiogenic shock. So primary thing, you must understand that there are 6 types: hypovolemic, cardiogenic, septic or vasogenic, neurogenic, traumatic, and obstructive. Now, septic shock is a topic on itself, which requires little more deliberations, or which we will discuss little more in detail in the next class. And most of these other types of shocks, there will be an overlap of hypovolemia. So that you must understand that the concept or the main factor, there will be decreased intravascular volume, which is beyond reversible stage, which will cause all these types of shock. Now, to look at this, what happens when there is injury to the tissue or cell? There will be primarily, I hope you can see the arrow, when there is decrease in perfusion or oxygen delivery is decreased, the tissue perfusion decreases, and this causes multiple problems. Number one is the cell injury, which can cause because of lack of oxygenation. And secondly, there will be endothelium of the vascular bed, which can have microcirculatory damage. And this endothelial and microcirculatory damage will cause aggregation of platelets and fibrin products, and this will occlude the peripheral vessels, which can still further cause decreased tissue perfusion, and this cycle continues. Now, the effect of decreased perfusion is because of that the muscle, heart muscle cannot function properly, and peripheral pooling of blood will be there. There is decreased venous return, and cellular hypoxia also causes intracellular fluid loss. Now, whenever there is cellular hypoxia or oxygen delivery is hampered, the cells start metabolizing anaerobically. So you must be clear, it is anaerobic metabolism, and the end product of anaerobic metabolism is lactic acid. And this will cause metabolic acidosis. So one is decreased venous return. Second, there is metabolic acidosis. There is which causes cellular permeability, and the fluid and sodium comes out. And because of this, there is coronary decreased perfusion of coronary vessels, indirectly affecting the cardiac output. So this is the vicious cycle which happens in shock. So you must understand cellular hypoxia and decreased tissue perfusion are the primary causes which cause cellular injury, endothelial activation of microcirculatory damage, cellular aggregation, and the blockage of peripheral vessels. Decreased venous return because of tissue perfusion, decreased metabolic acidosis because of the anaerobic metabolism, and which causes cellular damage, intracellular fluid loss, and decreased coronary perfusion and decreased cardiac output. So this is the whole essence of shock. And in various types of shock, most of the things happen. But in some situation like infection, these parenchymal cellular damage, aggregation, endothelial activation, all these will be more pronounced than compared to other types. In hypovolemia, there is decreased venous return. But then the cellular hypoxia will cause all these changes. So this is the basic change or pathophysiology of shock, which will be, you must remember this. This is the basis of entire shock. The basis of the etiology and the management is dependent on this, which is shock cycle. Now, the problem is when the blood pressure or the cardiac function reduces due to hemorrhage, and when the minimum loss is 30% of the body volume, then the manifestation of shock will come in. The mean arterial pressure will reduce only when minimum 30% of the intravascular volume is lost. Beyond that, it will have, now initial stages, the body tries to recompensate. They compensate by increasing peripheral resistance and secreting hormones like antidiuretic hormone, ACTH, all this. And then they try to replenish the volume and try to prevent the progression. But as the hemorrhage continues, the loss, then the stage of decompensation happens, but still it is reversible at this stage. Beyond a volume loss of more than 30 to 40%, it will go into irreversible state. And most of the time, if it is more than 50%, death will ensue. So this is how the hypovolemia or hemorrhage will cause the shock and changes. So you must remember that mean arterial pressure will reduce only when the volume of the lost volume is more than 30%, and beyond which it will progress into decompensated state and stage of irreversibility. Now, primarily, what happens in shock? The entire body tries to compensate it by various mechanisms. One is the neuroendocrine and inflammatory mediator response. Now, this inflammatory mediator response happens in classically when there is infection. When there is infection, there will be response from the host by producing various inflammatory reactive products which will cause cellular damage and tissue injury. Now with this COVID or the coronavirus problem, the main problem for the person is the reaction of the host towards the viral antigen. And that is the inflammatory cascade which progresses beyond reparability. And there will be neuroendocrine. The adrenal starts secreting adrenaline and noradrenaline, and pituitary. All these organs, they will secrete hormones which try to build the pressure in the vascular compartment. They try to maintain the thing by increasing cardiac output, increasing the heart rate, and increasing the stroke volume. So all these are due to neuroendocrine response, whereas the inflammatory response damages the tissue. So our aim in treatment of these individuals is to reduce the focus of infection and to try to reduce the amount of inflammatory response to this infection. So like I mentioned, ACTH, ADH, and other hormone like adrenaline, then noradrenaline, all these are secreted in response to, like I mentioned, fight or flight response. and these will try to replenish the volume by preventing further loss and increasing the cardiac output and cardiac rate and stroke volume. Now, circulatory response. In shock, what happens? Especially in infection, there is peripheral pooling of blood. That venous capacitance vessels have been not responding to the hormone. So this circulatory response, that is the reason why inotropes are utilized to increase the peripheral pumping of the blood, and so that the circulation, venous, and the main thing is when there is loss of intravascular volume, the blood to the main organs like brain and heart are maintained at the compensation to reduce the blood supply to the organs like skin and intestine and maybe kidney later on. So that is the reason in a patient with shock, you will find them, there is the skin will be cold and clammy, and there will be the bowel distension that can happen because of the lack of the peristalsis, which is due to the lack of blood supply to the intestine. So the body tries to preserve as much as possible the blood flow to the main organs like brain and cardiac muscle. And that is the reason why peripheral shunting, the blood will be transferred to this, and there will be changes in the peripheral areas which do manifest in shock. And there are, like I said, cellular effects. When the cells are damaged, the lysosome releases the intracellular enzymes. These cellular lysosomes will cause multiple cellular injury, and the permeability of these cells is increased. Fluid from the cell will come out, and there will be sodium loss also. Now, in the inflammatory response, there is also immune response. The cells also respond by producing multiple immune hormones like cytokines, prostaglandins. All these try to reduce the amount of inflammation and to try to maintain the intravascular pressure so that the perfusion to the main organs are maintained. So this is the basic thing. Like response is from the multiple systems trying to recover the lost pace in either its hypolemia or infection. All these responses will be seen, and in some types of this thing, the responses will be more compared to other responses. Now, this is the primary thing. Now, there will be, because of the infection and the microbe, there will be reaction. All these lipopolysaccharides are released, and there will be in trauma, there will be tissue injury. So, there will be different type, like this will be due to infection, septic shock. This is due to traumatic shock, and this is due to hypovolemic shock or hemorrhagic, and the neurogenic shock and cardiogenic shock. So these are the 5 types which we discussed. This is due to infection. This is the reaction of the host to the bacteria, and this reaction causes the cellular damage, and these lipopolysaccharides are released by the cell, which will cause the other reactions, like we said, immunogenic reaction. Now, when there is trauma, there is tissue injury also, and there is damage associated molecular patterns. All these things are released, and they will act on the recognition receptor activation and cellular activation. And in hemorrhage, there is decreased volume, and hence tissue perfusion is lost. These receptors, all these hormones or these products, they cause cellular activation and decrease tissue perfusion, which will cause cellular hypoxia and ischemia, and the end stage will be shock. So, you know the various mechanisms, what we discussed earlier. One is due to infection, disruption of host microbe equilibrium. Second is traumatic, where there is tissue injury along with loss of blood. A third is hemorrhagic shock or hypovolemic shock. Then there is neurogenic shock because of decreased tissue perfusion, and cardiogenic shock, where there is the heart muscle is not pumping properly. This is the entire thing is the basis of how the manifestation do happen. And looking at these, what are the problems envisaged in this situation, the management is also important to break this cycle. Otherwise, this is a continuous vicious cycle which will keep reaching the stage of irreversibility and then finally death. Now, same thing, like I mentioned, there is inadequate perfusion. So the basic thing in shock is inadequate tissue perfusion. That should be very clear. Because of that, there will be less oxygen supplied to the cells, and this will cause cellular hypoxia. There will be energy deficit in the cells because there is no oxygen to metabolize. So they end up doing what is known as anaerobic metabolism, and this will cause lactic acid accumulation. And because of this metabolic acidosis, there will be fall in pH, and that will cause metabolic acidosis. And this acidosis itself will cause vasoconstriction, which will cause failure of the precapillary sphincters to act, and hence the blood will be pooled in the periphery. So there is no enough volume of blood which is maintaining the milieu interior. There is peripheral pooling which is not being returned to the heart. Now, this metabolic acidosis will cause cellular damage, membrane dysfunction, and failure of sodium pump. And this will cause, because of the cellular damage, the lysosomes are released. These are digestive enzymes which will cause efflux of potassium and influx of sodium and water. And this causes cellular edema, and which will lead to cellular death. Now, because of these enzymes, there will be toxic substances in infection which enter the circulation, and capillary endothelium is damaged, further dysfunction and destruction and cellular death. So you must remember the primary thing, the fact which starts is inadequate perfusion, hypoxia, energy deficit. There is anaerobic metabolism which causes acidosis, and this acidosis will cause vasoconstriction and peripheral pooling of blood. Acidosis also causes cellular membrane dysfunction and failure of sodium pump, release of lysosomes, which are digestive enzymes, efflux of potassium and influx of sodium and water causes cellular edema, and functioning gets hampered. In infection, also there is toxic substances because of the bacterial products into circulation, which damage the capillary endothelium, and further destruction, dysfunction, and cellular death happens. Now, I hope you are clear about the pathophysiology of shock and types of shock and what is shock per se. If you are clear about that, the signs and symptoms and management will be easy. You will understand that each of causative factor you have to treat in this scenario to overcome the existing problem. I hope you are all clear. Now, the signs and symptoms. The signs and symptoms depends on the type of shock. Like I mentioned in the beginning, hypovolemic shock is the most commonest type of shock. You must remember it can come for NEET, MCQs. Commonest type of shock is hypovolemic shock. So you must remember that. And there, the patient will manifest with, or individual will manifest with anxiety, restlessness, altered mental state. This is a progressive changes from anxiety to restlessness to altered mental state is progressive. Please remember this. This is one of the factors which are assessed, to especially in cases of sepsis and in patients who are admitted in intensive care unit to look after the sepsis and infection process. Now in hypovolemia, when the manifestation is the loss of fluid is more than 30% of intravascular volume, a patient who is 70 kg will have at least 3 liters of intravascular volume. When there is loss of more than 30%, all these manifestation will come in. Till then, there will be compensatory mechanisms and there may not be any obvious signs and symptoms. But then the process of blood loss can be going on. So it is our duty and responsibility to evaluate the patient if it is a case of trauma to ensure that there is no bleeding or to control the hemorrhage. And next I said, because of the loss of the circulatory volume, more than 30% of the intravascular volume, then the hypotension manifests. Usually when the loss is about from 10% to 30%, the changes may not be so clear. But hypotension, that is the mean arterial pressure of less than 70 millimeters of mercury, is seen when the loss of intravascular volume is more than 30% of the volume. So that should be very clear. And because of this, there will be decreased cardiac output, and hence the heart tries to make it more by trying to increase the rate so that the cardiac output is maintained. When the volume, stroke volume decreases, it will try to, that is the Starling's law. I hope I remember correctly, and you also remember, like, cardiac output is equal to stroke volume into heart rate. So when the stroke volume decreases, to maintain the cardiac output, there will be increased heart rate. And this will manifest in a rapid weak because there is volume is less and it will be 3D pulse. So this is the commonest signs and symptoms of hypovolemic shock. And usually all these manifestations happen when the volume loss is 30%, minimum 30% and above the intravascular volume. Now in hemorrhage, because of the loss of intravascular volume, they have classified this hemorrhage into class 1, class 2, class 3, and class 4. The main thing is less than 750 is class 1. Between 750 ml, 1500 ml of blood loss, it is class 2. 1500 to 2000, it is class 3. And class 4 is more than 2. So somebody's volume, blood or intravascular volume is 3 liters. You can imagine what changes can happen here when it is less than 750 and here when it is more than 2 liters. So when there is less than 15%, the heart rate will be less than 100, pressures will be normal, there won't be central nervous system symptoms. In class 2, when the blood loss is about 750 to 750 ml to 1.5 liters, the blood loss is around 15 to 30% of intravascular volume. Heart rate will become more and more than 100. And when you make the patient to stand, he will feel dizzy, giddy, and that is due to orthostatic hypotension. And they will be anxious, like we saw in the previous slide. Anxious, then they are confused, then they go into sensory obtundation. When the blood loss is more than 1.5 liters to 2 liters, it is nearly 30 to 40% of intravascular volume. Heart rate will be more than 120. There will be manifestation of hypotension. Like I mentioned, more than 30% of the intravascular volume. There will be changes in the mean arterial pressure. Patient will manifest with hypotension, and there will be decreased perfusion to the brain and patient will be confused. But when it is class 4, that is more than 2 liters of blood loss, and it constitutes more than 40% of the blood loss, then it will be, heart rate will be very rapid, more than 140, and severe hypotension will be there. Severe hypotension is when it is not responding to fluid replenishment and the mean arterial pressure is less than 40. And central nervous system will be more pronounced in this situation, and they will be so confused you can't make out what is happening. So all these are essential things, and you will be able to guide them and to do resuscitation depending all these physical findings and your examination. So this is very essential to know when these changes have happened, that the loss may be this much. When these changes are there, loss is around this much. You must try to replenish the intravascular volume and as well as prevent the further loss of blood or intravascular volume. Now, continuation of these stages, it will be when it becomes more severe, the periphery will be cool, clammy because of vasoconstriction and pooling of blood, and there will be increased respiratory rate. Rapid increased respiratory rate usually happen when the loss in class 3 and 4 of hemorrhagic shock. And because there is loss of fluid, and there will be, and you are trying to replenish by giving fluids, there will be loss of body temperature, and this hypothermia also contributes to vasoconstriction and decreased perfusion. So you can imagine hypothermia, vasoconstriction. Because of less vascularity and when they say they are very thirsty and dry mouth, rapid respiration, you have to ensure that this is happening and you must replenish the fluid immediately. Fatigue, inadequate oxygenation, tissue oxygenation is lost. So there will be, they cannot do anything. They won't be even able to sit up and do the normal things. Now this cold and mottled skin, and especially in the extremities, and this is known as cutis marmorata, and this is classical of hypovolemic shock. So when there is cold mottled skin, this is known as cutis marmorata, and especially in extremities you can make out these changes. So this can be a MCQ for your NEET. Now coming to the cardiogenic shock. Cardiogenic shock, there is basic injury to the myocardium. There will be myocardial ischemia or infarction, or it can be due to myocarditis. And there can be additional changes because of hypovolemia also. But in hypovolemia, the jugular veins will not be distended. Whereas in cardiogenic shock, the jugular venous pressure will be increased and you will find distended jugular veins. So this is classical of cardiogenic shock, and you must be very clearly able to make out this distended veins and the pressure is low. This is due to cardiogenic shock, and it is due to myocardial infarction, myocarditis, and you must be able to treat these patients. So remember, in a shock patient, if the jugular veins are distended, think of cardiogenic shock until proved otherwise. And there can be, because of this, when there is rapid pulse, which is thready, you may not be able to feel, which you may think it is pulse is absent, but it is due to tachyarrhythmias, which can manifest in myocarditis or myocardial infarction. So the classic physical finding is there will be hypotension, absent pulse, but the jugular veins are distended. This is very classical. Whenever you find like this, think of cardiogenic shock until proved otherwise. Now, the obstructive shock. Obstructive is due to obstruction to the outflow of the heart. And this happens in cardiac pericardial effusion when there is constrictive pericarditis, or when there is pneumothorax, which is compressing on the mediastinum. The heart is not able to function, but primarily the myocardium is normal in obstructive shock. And the manifestation will be similar to hypovolemic shock, which we dealt earlier. And the jugular veins will be distended, and you will not be able to hear the cardiac sounds properly, especially in cardial effusion, and in cases of pneumothorax, you will be difficult to make out the cardiac sounds. And pericardial effusions are there because of myocarditis. Then also it can obstruct it becomes like constrictive pericarditis, and heart is not able to pump because of this obstruction. One of the classical feature of obstructive shock, that means obstruction to cardiac outflow, is pulsus paradoxus. In normal individual, when there is deep inspiration, the pressure usually decreases, but not more than 10 millimeters. And the pulse also increases, whereas volume decreases. Whereas in case of obstruction to the cardiac outflow, when there is deep inspiration, the fall in blood pressure is more than 30. And the pulse volume also decreases in deep inspiration. And that is the reason, even though volume is good, the pulse is low. Pulse volume is low, you are not able to feel, or you will feeble pulse will be felt. And this is classically is seen in cardiac tamponade. It can be due to hemorrhage or effusion. When there is more constriction on the myocardium, cardiac tamponade, this pulsus paradoxus can happen. In other situation where pulsus paradoxus is seen is myocarditis, and even in mediastinal obstruction causing dampening of the cardiac output. Now, septic shock, like I said, it is primarily due to bacteria and the infection which causes and the host reaction towards this. It is cellular and immunogenic reaction toward this focus of infection which causes the changes in septic shock. But initially, because the changes will be similar to hypovolemic. So now you must have seen all types of shock have these classical features of hypovolemic shock. But there are specific features which indicate what type of shock it is. And in septic shock, there will be hyperpyrexia or fever because of bacterial infection. And this can go into hypothermia also. So don't think that always there should be fever. No. But presence of fever indicates that there must be a focus of infection, and it is our responsibility to ensure to look into this focus of infection so that it can be either surgically or medically treated. So hyperpyrexia, then cardiac output is increased because of peripheral vasodilatation, which happens in sepsis. So the initial changes may be like hypovolemic shock, but later on the sepsis and these immune changes which have happened will cause further changes which will be classical or typical of septic shock, which we will deal separately, because I think as practicing physician or a medical final year student, you must have clear view or clear idea about shock and sepsis. I really, sometimes I feel sorry. Postgraduates, they don't have proper knowledge about this shock and sepsis. You must have basic knowledge of shock and sepsis, which will help you in the long run even when you're doing your post-graduation or as practicing physician, the basis will remain same. The There may be terminology changes, everything, but the basic manifestation, basic management will remain same, and you must be thorough about it. Now, there is another entity called anaphylactic shock. This happens especially when some drug is given or some allergic to something, and these they suddenly collapse. There will be classical skin eruptions, and there will be changes. Large welts will be there, and there will be a main important thing is that there will be edema, especially around the face. This is classical case of angioneurotic edema, which will be typical due to because of these allergens. And usually it happens bee sting or some other insect bite or allergic to something or drug when it is given. And that is the reason skin tests are ideally instructed to be done to prevent this anaphylactic shock. And you must ensure patient, once he collapses, it is very difficult to resuscitate him. So if you are going to be a radiologist or any other who is going to inject contrast into intravenous region, be careful of this. And there will be skin eruptions, classical, and you can even see the lymphatic vessels which are red, dilated, pulse becomes rapid and thready, and because of this causing pharyngeal edema, there will be occlusion of airways and swelling of throat, which is in an emergency situation. You must, in this classical management, is to ensure stretching adequate sort of airway to be maintained or established, and give hydrocortisone to reduce all these anaphylactic reaction and manifestations. Now, just to summarize the whole thing, hypovolemic shock, cardiogenic shock, distributive shock, which happens in sepsis and in trauma, and obstructive when it happens in cases of cardiac effusion, myocardial effusion, and in cardiogenic shock, it is due to myocarditis or myocardial infarction. Hypovolemia, there will be decreased central venous pressure. In cardiogenic shock, because of the obstruction, CVV will be raised. That's why you will find distended jugular veins, classical. So when you find distended jugular veins with hypotension, think of either cardiogenic or obstructive shock. When there is CVP is low or no jugular vein, think of hypovolemia or distributive or septic shock. Cardiac output in hypovolemia is decreased, in cardiogenic is also decreased. In distributive, initially there will be decrease, then the compensatory mechanism tries to take up. In obstructive, there is decrease. Now, systemic vascular resistance will try to increase so that the volume is, towards the heart. And in cardiogenic shock also there will be SVR, but in obstructive also it will be increased. Whereas in sepsis, because of peripheral pooling, due to this infection and immunogenic reaction, there will be peripheral pooling, venous capacitance vessels, they are not responding to adrenaline, and fluid is retained in the third region, that is called third space loss. Clinically, in hypovolemia, there will be cold and shutdown. Same thing happens. But in distributive or sepsis, patient may have fever and warm and dilated this vein. And in obstructive, it's difficult to make out. So this is primarily what happens in different types of shocks. You must remember, one is central venous pressure, pulmonary capillary wedge pressure, cardiac output, and systemic vascular resistance, and clinically how you can make out. So these are the things. If you are aware of these things, you'll be able to diagnose any type of shock and manage them. Now, just a word about, previously we used to talk about systemic inflammatory response syndrome, especially in cases of sepsis. Now, the terminology has lost its value now because there is no validity and there is no uniformity. So the recent in 2013, they came out with a sepsis. The whole team came out with a new idea or new way of scoring the system. This is sepsis related organ failure assessment score, also known as SOFA, which we will deal later in when I will take class on sepsis. So this is an important thing. So systemic inflammatory response syndrome is not used anymore, and please don't use it. But the changes will happen, like leukocytosis in infection, but it is no more used. Now what is now used is SOFA, SOFA scoring. So sequential organ failure assessment. Now, now since we are clear about the etiology, manifestation, clinical signs and symptoms, our main aim is to diagnose early and establish therapy so that the chances of recoverability will be higher. Now, goals of therapy is re-establishing perfusion to the organs. That is the main. How will you establish? You have to replenish the intravascular volume. Oxygenation has to be the thing. So it is similar, ABC. Ensure that there is proper airway, breathing is normal, and you have to circulatory. You have to replenish fluid volume. So all these things are essential, primarily to ensure adequate oxygen perfusion to the organs by ensuring ABC, airway, breathing, and circulatory. And other aim is to prevent complications of shock. So these are our primary aim, and all our efforts should be there to ensure that we should get back into the stage of normality. And once it goes to irreparable stage or reversible stage, it will be difficult. So management, make sure you get a good venous access, two venous lines, and give fluids. There is argument regarding what should be given. If it is due to hemorrhage, blood is the ideal replacement. Till you get the blood, the grouped and matched, cross-matched blood, give IV fluids. Now, amongst the IV fluids, there is some crystalloids and colloids. Now, crystalloids are like normal saline, Hartmann solution, Ringer lactate. Colloids are albumin and other like hextron. That now these are all, they just increase the volume initially, but then they don't maintain. But in patient with shock, there is always what is known as you have to give them adequate fluid to ensure that to see whether there is hypovolemia or not. Once you make out that there is hypovolemia, you give them fluid challenge. Now, when you give rapidly run 750 ml to 1.5 liters, if the pressure increases, rate comes down, that means it is due to hypovolemia. Now, if the pressure comes up and it is not maintaining, that means there is continuous loss of intravascular volume. That means there is bleeding. If the pressure does not come up, that means it is due to obstruction or cardiogenic shock. So that is the premise of giving fluid challenge. And you must be very clear, 750 to 1.5 liters, run it over 15 to 20 minutes. If the BP increases and it falls down, that means there is continuous loss of blood. If the BP increases and maintains, that means there is intravascular volume loss. And if there is no change at all, it is due to cardiogenic or it is due to obstructive. Always give supplemental oxygenation because tissue perfusion is low, and patient should be catheterized to monitor urinary output. At least our aim is to ensure at least 0.5 to 1 ml per kg per hour. That should be the ideal thing. In cardiogenic shock, like we said, arrhythmias, myocarditis, you can give colloid. Whereas if there is cardiogenic shock or obstructive, don't give colloids for these patients. Ensure oxygenation, maintain tissue perfusion. Our aim should be to maintain mean arterial pressure above 70 to 80 millimeters of mercury. You must ensure that, and monitoring JVP or central venous pressure is not a good indicator of. It can be showing higher, but then there even in obstruction it can happen. So our main thing is pressure, which is maintaining mean arterial pressure, urine output, which is more than 0.5 to 1 ml per kg per hour. These are the monitoring things which we have to ensure to manage these patients with shock. So all these things which I have mentioned, hypovolemia can be caused due to burns, gastrointestinal loss like vomiting, diarrhea, urinary loss, diabetes. So primary thing is there is intravascular volume depletion. That is what happens. It can be hemorrhagic shock or non-hemorrhagic. Hemorrhage means there is either external hemorrhage or internal like abdominal trauma. All these things are which can give rise to hypovolemia. And cardiogenic shock, which I mentioned, myocardial infarction, contusion, post-trauma, myocarditis, post when there is cardiac bypass, they have done valve replacement. All this can manifest with cardiogenic shock. And here, our aim is to control arrhythmias, reverse myocardial ischemia. Specific treatment for myocarditis, and if there is problem with valve replacement, open heart surgery. Now, in septic shock, which we'll be dealing with, you must primary aim is to give or treat the focus of infection. If it is surgically needed, go ahead and treat. And intravenous antibiotics, systemic antibiotics according to the culture sensitivity. When there is no immediate culture sensitivity available, give broad spectrum covering anaerobic organisms also. So in distributive, it is not only sepsis. It can happen in anaphylaxis, in spinal shock, and even in hyperthyroidism and liver dysfunction. There is distributed, that means there is no obvious external loss, but fluid from the intravascular has gone outside and there is peripheral pooling, and that is why it's called distributive shock. Our aim is to give fluids and reverse all these changes which can happen. So here a good inotropic agent, which is dobutamine, which can be used, but our main aim is to reverse the primary cause and try to correct that. In anaphylactic shock, main treatment is hydrocortisone and adrenaline, and in sepsis, treat the underlying cause. So obstruction, you must immediately relieve the thing, tension pneumothorax, and or if it's cardiocentesis, you have to do to cardiac, remove the cardiac tamponade, or there is pulmonary embolism, give anticoagulants, or which will give rise to. So our main aim is to get the fluid resuscitation, release the tamponade, and for temporarily, inotropes can be used in obstructive shock also. So that is about the shock. So just to summarize, shock is due to inadequate tissue perfusion and there is no oxygen supply to the cells and the tissue. So the major problem is lack of oxygenation and the cellular changes which happen. The various types of shocks are the commonest type of shock is hypovolemia, and the manifestations do happen when the intravascular volume loss is more than 30%. In sepsis, it is due to infection, which the cells or the host reacts to it and which causes all the changes. In obstruction, it is due to cardiac outflow obstruction like tamponade or in pneumothorax like that. But in cardiogenic, there is primary damage to the myocardium like myocarditis or myocardial infarction. So clinical examination is absolutely essential, and all the findings look for that which will help you to differentiate between various types of shock. And primary aim of management is to not to allow the patient to go into the phase of irreversibility. Main aim is to re-establish adequate oxygenation, perfusion of tissues, fluid or volume replenishment, and specific when there is type of shock is diagnosed. In cardiogenic, you got to treat the myocardial infarction, supportive measures have to be given, treat the arrhythmia. In obstructive, you have to relieve the obstruction, cardiocentesis. In pneumothorax, you put in a chest tube, you relieve this obstruction. And in sepsis, try to treat the focus of infection either by surgery or by antibiotic therapy. But the main aim is to establish the intravascular volume, which is the basis of all the types of shock. Commonest is hypovolemia, intravascular volume depletion, which is depleted, which will cause all these things. I hope you have understood the primary concept of shock, what are the manifestations, what are the types of shock, and how you have to manage these patients individually and different, and how to differentiate. I hope you have understood. If you have any questions, please send it forward. I will try to answer to the best of my ability.
Thank you, sir. It was a wonderful presentation, sir. I would say that it's classic and all the salient points of shock. And as you say, every MBBS student should know shock. It's very important. We will wait for another 2 minutes, sir. If there are any doubts, I will forward it to you. Students, if you have any doubts, please type it in the chat section. Okay, so meanwhile, please share our YouTube channel, www.tinyurl.com/Indian Medical College 2020. Please do like our Facebook page, www.fb.com/Indian Medical College 2020. We are sharing a lot of MCQs in Google Forms. You can try those MCQs. It will be nice and fun. And we do have upcoming session on surgical anatomy of tongue anatomy at 6:30 to 7:30. It will also be an interesting talk by Dr. D.H. Gopalan from Tagore Medical College, Chennai. And tomorrow also we have very interesting sessions. Session 1, blood supply of brain by Dr. Geeta ma'am. And 5 to 6 p.m. We have a pathology session on nephrotic and nephritic syndrome by Dr. Srikant Bharati. And 6:30 to 7:30, wonderful talk by Dr. Ajit Kumar, ENT, on interpretation of pure tone audiogram and impedance audiometry. It will be a wonderful session to enjoy tomorrow. Please do stay tuned. With no other doubts, we'd like to wrap up the session. Thank you very much for listening. Stay tuned for another session at 6:30 p.m. Thank you. It's signing off, Dr. Balaji. Thank you.